Hello everyone. Today we are trying to talk a little about acid-base balance disorders. I hope you have the supplementary slides, and this short video tutorial is going to expand somehow the knowledge that we should get from it. I will skip the glossary since I hope that everything here is easy and clear. Of course, we receive every day lots of various organic substances which are turned into acids during metabolism, and one of the acids is here. Which is actually lactic acid. Acid-base balance refers to relatively stable reaction of body of inner environment, which is expressed by concentration of hydrogen ions, or much commonly by its negative decimal logarithm pH. That is what we actually lose for evaluation. And it's important to mention that normal arterial blood pH is not actually neutral. It is slightly basic normal. It is 7.40. Below which we consider to have acidemia or alkalemia. Here also better to write acidemia or alkalemia instead of acidosis or alkalosis, which are actually the processes correspondingly leading to acidemia and alkalemia. And the normal range, let us consider 7.38 to 7.42. It is quite narrow range, and we should try to keep arterial blood pH within these narrow ranges. Main indices of acid-base balance, there are lots of them, but I would like us to concentrate on these three ones, most important ones. The pH that we have, concentration of carbon dioxide in arterial blood again, and standard bicarbonate, which if we take simple is just concentration of bicarbonate in the blood, but actually it is standardized. And some reference ranges are given here. Again, we put here two more strict values of 738 to 742. For CO2, it is 38 to 42, with optimal one being 40, easy to remember, and bicarbonate 24 with plus minus 2 millimoles per liter. Some additional values are given as lactic acid, lactate in the blood, ketone bodies, and the last two are related to urine. Titratable acidity, so-called, which is measure how much kidney is excreting acids, and the index of ammoniogenesis, which is ammonia in urine. To continue, let us consider this experiment in which dogs received an infusion of 14 millimoles of hydrogen per liter of body water. This caused a drop in pH from 7.44 to pH of 7.14, which means a rise in H plus only 36 nanomoles per liter. So it means that the change in hydrogen ion concentration just 36 nanomoles per liter, and we should wonder what happened to the other 13,009,099 and 964 nanomoles per liter, because we infused much more. We infused 40 millimoles, and I hope you get the answer. All those additional molecules of hydrogen ions were actually buffered, and therefore we should consider our buffer systems. Each of them usually is a pair of acid and corresponding base, so it can and should buffer acids that we add to. They have their capacity, which is shown on following slides. in plasma and red blood cell. Altogether are our blood buffers, but the next slide, this one, shows better which of them works where. For example, here is shown site, and in interstitial fluid we have of course phosphate and protein buffers, but they are not so much important because of low concentration, while bicarbonate here is important. In blood, most important are bicarbonate buffer in case of metabolic acids, some role of hemoglobin for carbon dioxide. Plasma protein here is minor buffer, and phosphate again not that important. But for intracellular fluid, both proteins and phosphates become very important buffers. In urine, we have phosphate considered to be buffer, too important, as we'll see later, as well as ammonia, and we have role of bone as buffer since it provides calcium carbonate and has some role in compensation of metabolic acidosis. This slide provides us some examples and main mechanisms how different organs participate in acid-base balance, but we should emphasize two of these organs much more than others. They are lungs, which regulate acid-base balance through change in ventilation and corresponding change in CO2, which will become one of the most important components that we have. And kidneys. So our respiratory component and metabolic component are related here. And kidneys participate in acid-base balance first of all by reabsorption of bicarbonate. And two additional mechanisms that we will be talking about are acidogenesis and ammoniogenesis. But of course other organs have also their role, like liver with its ability to uptake lactic acid, and through gluconeogenesis we make glucose, which is neutral, etc. Especially some difficulties to understand acidogenesis, so let me provide short explanation how it happens. We should consider this is epithelium of tubules, vessel lumen, and here is the urine flow. And first of all, the point is that we uptake carbonic dioxide, CO2, from the blood, which then by help of enzyme carbonic anhydrase is converted into H2CO3, which then gives us H plus and bicarbonate ion. H plus then is secreted to the lumen of the tubule. Commonly it happens through exchange with sodium, which is ATP dependent process. But what is important then next is acid, which is secreted here, is buffered by help of our phosphate buffer, and as a result we see that this H is exchanged for sodium, and that additional sodium comes back, joins with bicarbonate ion, and so sodium bicarbonate comes back to the blood. So we took from here CO2 and gave back sodium bicarbonate. Thus we provide some anti-acidic event here. The other mechanism that is of special attention is ammoniogenesis, which is actually adding something supporting acidogenesis, and it is in part very much the same, especially at the beginning. Again, carbonic anhydrase is required for conversion of CO2 into H2CO3 with then hydrogen ion, and it is again secreted to the lumen of the tubules. But before that we have additional step, which is by help of enzyme glutaminase, conversion of from glutamine, ammonio group is taken, so that NH4 plus ions now are made and they are secreted to the lumen, and the result is that we can now by making of these ammonio ions do not make a acidic, the urine much more acidic. Instead, chloride ions are exchanged, and some chloride ions join with NH4 plus, and the released sodium again comes back, joins with bicarbonate, and the result is formation of sodium bicarbonate again. So overall, again, we took CO2, acid, and gave back base, sodium ACO3. Now we should try to talk about typical disorders, about acidosis and alkalosis, the processes, and to understand the changes that we have, we should keep in mind Henderson-Hasselbalch equation, which is about 100 years old. And the main idea here is that pH depends on relation of ratio of bicarbonate and CO2. And pH of the blood, one of interpretations that we may provide, would stay constant as long as constant would be the ratio of bicarbonate with CO2. Which means that if due to some reason we have, let's say, decrease in bicarbonate concentration, let's say due to some metabolic acidosis, and acids, synthesized acid would decrease bicarbonate concentration. To keep pH constant, we need to decrease concentration of CO2, which will be achieved by help of lungs. We will exhale some additional amount of carbon dioxide, so that metabolic acidosis would be compensated by respiratory alkalosis, and vice versa. Here is classification of acid-base balance disorders. It could be by origin exogenous or endogenous, local versus general, by duration acute and chronic, compensated and decompensated. Usually we consider that acid-base balance is decompensated when the pH runs out of the range 7.35 to 7.45. Out of this range we consider that the disorder is decompensated. And much important for our discussion classification is its classification into acidosis and alkalosis, respiratory and metabolic. Most important 4 types. And as we mentioned, as it follows from Henderson-Hasselbalch equation, once we have hypoventilation and accumulation of carbon dioxide in the body, the initial shift would be hypercapnia, which decreases pH. And to compensate this, bicarbonate ion concentration should also increase to keep this ratio stable. And this is achieved first of all by help of kidneys, which will reabsorb more sodium bicarbonate, as well as will activate acidogenesis, ammoniogenesis. Then other organs also support the balance. But one thing important to keep in mind is that kidneys require time for adequate compensation. Usually compared to lungs, which require just minutes to hours to compensate, kidneys require hours to days for full compensation because of difficult machinery required for that. In respiratory alkalosis, like in any reason for hyperventilation, the initial shift will be vice versa, decreasing carbon dioxide level, which increases pH. To compensate, we need to decrease bicarbonate. So that in respiratory disorders, the main cause is initial change in CO2. As a consequence, we have change in this ratio, so that, as we mentioned in respiratory acidosis, initially we have increase in CO2, so to compensate we need to increase bicarbonate, and in alkalosis, respiratory alkalosis, compensatory shift would be decrease in bicarbonate concentration. In metabolic acid-base disorders, the cause is initial change in bicarbonate concentration. which independently of the fact is it due to accumulation of acids like in lactate acidosis or ketoacidosis, or if it is initial decrease in bicarbonate concentration due to loss of bicarbonates or any other reason, we consider initial change to be bicarbonate. So in metabolic acidosis, the decrease in bicarbonate concentration leads to decrease in pH, to compensate which we need to decrease CO2 concentration to keep that ratio constant. And in alkalosis, we have initial change, increase in bicarbonate concentration, which increases pH, to compensate which we should have compensatory respiratory acidosis. In order to differentiate between metabolic acidosis, which has lots of different causes, very useful is measurement of so-called anion-gap. The idea is that normally within serum we have some cations and anions, and of course some of positive ions like sodium, potassium, calcium, magnesium, H+ ions, some other unmeasured cations, as well as some of chloride, which is most abundant, as well as bicarbonate, phosphates, sulfates, etc. All of them, if we add, the equilibrium should exist. Means normally there is no anion gap, it is zero, because the serum is electron neutral. But in all of the cases we have some so-called unmeasured anions. Usually in the lab not all these cations and anions are measured. So in terms of simplicity and usefulness, it's very useful to consider out of all cations only sodium, because the remaining potassium and others are very low in concentration. And out of all possible anions, we consider only chloride and bicarbonate. So that we will define anion gap as sodium minus chloride and bicarbonate. The result may be different from different labs, but usually it is something about 12 millimoles per liter. And the reason why this is very important is being able to differentiate in different causes of metabolic acidosis. So we measure only these three ions usually, sodium, chloride and bicarbonate, for anion gap. And in case that the anion gap is increased in metabolic acidosis, it means that we have increased amount of those so-called unmeasured anions, like for lactate. So that if we have metabolic acidosis due to accumulation of lactate in the blood, the anion gap would be higher. Here is very useful mnemonic, gold mark, which allows us to think about most common causes of metabolic acidosis with high anion gap. These could be glycols, oxoproline, L and D-lactate, methanol, aspirin, renal failure, which is not only a high anion gap, some types may be normal, rhabdomyolysis and ketoacidosis. Normal anion gap metabolic acidosis could develop either if we have loss of bicarbonates, so that it could be in some gastrointestinal conditions like diarrhea, renal conditions commonly if we are not able to properly reabsorb bicarbonate. That's why, like for example, renal tubular necrosis type 2, etc. Or if we have decreased renal acid excretion. Again, first of all, kidneys are involved here. Some other causes could involve increased fluid resuscitation with saline, which provides additional amount of chloride. And by differentiation of metabolic acidosis, measurement of anion gap is one of the initial steps that is important to consider in order to differentiate. In terms of bone buffering, I just wanted to mention that seemingly it seems like bone could do much, but in reality some buffering is specifically important in metabolic acidosis, and it is due to ability of bone to release calcium carbonate in these conditions. Before moving to a little mathematics, I just want to remind that before coming to specific numbers, most important is clinical evaluation, proper physical exam of the patient, because many things here could hint to future diagnosis. Like even without measuring of anion gap, etc., the patient would be expected to have metabolic acidosis if we know that he is diabetic, if we feel the so-called acetone factor from the patient, etc. So all this we should keep in mind before looking to the numbers. And here is the algorithm for evaluation of simple acid-base balance disorders. Step 1, we should look at pH, and we should from the first step differentiate. If it is more than 7.42, it is alkalemia, and if it is less than 7.38, it is acidemia. Second step, we evaluate standard bicarbonate and CO2. If we have increase in bicarbonate, it is metabolic alkalosis, decrease metabolic acidosis. And CO2, if we have its decreased respiratory alkalosis, and if it is increased, as we already mentioned, respiratory acidosis. Now, most importantly, step 3, we should determine the primary acid-base disorder and secondary response. The primary one would be the one which is in the same direction as it was the change in pH. The secondary would oppose changing the pH. It would be easier to look at the example. Suppose we have a patient who is 54 years old and he has some vomiting. And here are his data: pH 7.49, bicarbonate 33, and CO2 46. First step, pH is more than 7.42, means we have alkalemia. Secondly, if the bicarbonate is more than 24, the optimal, while we have 33, means we have metabolic alkalosis. And looking at CO2 level, which is 46, which is more than 40, means we have respiratory acidosis. So, changing pH CO2 corresponds with the change in pH, means we have sorry, it's wrong here, I should fix it. Changing bicarbonate. So changing bicarbonate ion, as we see, corresponds with changing pH, because we have metabolic alkalosis and we have increased pH, so alkalosis and alkalemia. Therefore, this is the primary disorder. While the change in CO2, again I will fix it, change in CO2. should be considered as the secondary response. So, as a conclusion, the primary disorder is metabolic alkalosis, and change in CO2, respiratory acidosis, was for compensation. But question arises, is this compensation enough to compensate? Probably the answer would be not enough, because despite the compensatory change, we have decompensated state. It is more than 7.45. But we, as we can conclude from some empirical data, we may predict how much we should have change in CO2 to say that lungs were able to compensate the change. That's why we have this table which will allow us to conclude about the adequacy in compensation. So to judge about this, use this table where it is mentioned here the primary disorder, what is corresponding primary shift, and expected compensatory shift. For example, in our patient we had pH of 7.49, bicarbonate 33, and CO2 of 46. So from the table we look to metabolic alkalosis. We confirm that yes, primary shift was increasing bicarbonate level, and the expected compensation increase in CO2 level is calculated 0.7 times the change in bicarbonate level. So we will do this calculation. The expected compensatory increase in CO2 level should be calculated 0.7 times 33, which is actually the bicarbonate level in our patient, minus ideal one, 24, and 0.7 times 9 would be 6.3. Okay, and in reality we had CO2 46 minus ideal CO2 40, which is 6. That is roughly the same as 6.3. Means that the compensation was adequate, and it also means that we do not have any superimposed change in respiratory system. Since we are discussing only simple acid-base balance disorders, we do not move to other fields, but the idea and point here is that if it is, let's say, much more, if the patient had much more CO2 level, not 46 but let's say 56, and if we calculate, we see that the difference is not 6.3 but let's say, I don't know, 10, it should point us to the fact that we have some additional problem in respiration. So in our patient, conclusion from this compensation adequacy table, we can say that compensation is adequate. To allow you some exercising for self-evaluation, please consider this situation. You have 4 patients here with their data. You should match which patient has which corresponding indices. I hope that I was clear enough to provide you some background for thinking. As an advice, before finishing this presentation, I would like to point to one of recent articles published in New England Journal of Medicine, which is about all these issues. It was published just a couple of weeks ago. Physiological approach to assessment of acid-base balance disturbances, where you can find lots of additional information that was not involved here. And at the end of this article, there are also some nice case examples which are very useful to consider. So that would be all for today. Thank you for watching and hope to see you in class ready.